how is a path decided then or determined for an individual patient? Is there key lab testing that can impact prognosis and treatment options?
Once a patient comes to the attention of the team, and that will usually be accompanied by some sort of biopsy, some sort of pathologic diagnosis to confirm that indeed we're dealing with, let's say, squamous cell carcinoma. Then the next thing we want to do is we want to stage the disease, and what that means is we want to know as much as possible or as accurately as possible where the cancer is and how big it is. So that would almost always involve scans, usually CT scans, sometimes a PET scan, and we can talk about the advantages and disadvantages of each. Sometimes an MRI in certain situations, but suffice it to say, some sort of scan, some sort of imaging that can tell us where the cancer is, how big it is, if there are any lymph nodes involved, and if that cancer has spread beyond the head and neck area. Once we stage the disease, most patients, and I think certainly most patients should, their case, that is, should be discussed at a multidisciplinary tumor board, where, again, all the specialists convene at the same time and really go over all the data that are available on that individual and come up with a treatment recommendation. That treatment recommendation can be a single modality. So some small tumors can just be addressed by surgery alone or radiation therapy alone. But for more advanced tumors, it is often all three modalities: surgery, radiation, and chemotherapy. And the way they're sequenced, the way they're implemented, should be individualized for that specific patient. Again, with those two goals in mind: to cure the cancer and to preserve function.
What else could guide a treatment decision? For instance, a patient's comorbidities, their age, things like that?
All of those things.
Yeah.
So beyond, and those are things, of course, that we would consider in the discussion, not only at the tumor board, but of course with the patient. We know that the therapy that we often recommend is quite aggressive and toxic. Now, the justification for that is that we're going to try to cure the cancer, and so we think, and of course we discuss this with the patient, that putting the patient through this course of treatment is worthwhile, makes sense, because at the end of it, the goal is for the cancer to be gone. Now, not all patients will agree with that, and of course, based on comorbidities and age and something we call performance status, we also want to make sure that the patient can get through this aggressive treatment. And let me just go on a bit of a tangent and describe the therapy for a patient with locally advanced head and neck cancer. It would involve about 6 to 7 weeks of radiation given Monday to Friday, usually either weekly or every 3-week chemotherapy, depending on the chemotherapy chosen, and possibly even surgery either before or after the combined chemotherapy and radiation. And so we're talking about at least a 3-month course of treatment when you going from the start to recovery, another 3 months of side effects that are less intense, but still there. And it's a lot for patients to go through, patients and their caregivers. And so if we feel that there's a serious comorbidity that would not allow the patient to do that, we sometimes have to alter treatment so that obviously we don't want to harm the patient with our treatment. Certainly, we don't want to put them in a life-threatening situation. So we do have to take those things into account. The good thing about all this, or I guess the silver lining, if you will, is that these toxicities get better. Patients recover. So what I tell patients is we're going to put you through hell, but at the end of it, I want to be sitting across from you and saying the cancer is gone and you're swallowing and you're talking normally.